Let us discuss about biguanides. The representative drug of this chemical class is metformin. There have been two other drugs, fenformin and buformin. However, these drugs have been withdrawn from the US market. So the clinically used drug of this class currently is only metformin. Okay. So what does metformin do? Okay, so what's the mechanism of action of metformin? Okay. So MOA refers to, is an acronym for mechanism of action. Okay, so how does it work is what we're going to discuss now. So recent evidence shows that metformin stimulates AMP activated protein kinase. Okay. This is abbreviated AMPK. Okay. AMP meaning adenosine monophosphate. Okay, and in doing so, what does it do? It stimulates this kinase and decreases hepatic gluconeogenesis. Okay. Then what it does is it increases glucose sensitivity. Okay. It increases the glucose sensitivity of peripheral tissues. Then it increases glucose uptake in the periphery. Okay. Okay. And it has got cardioprotective effects. Okay. So this drug has got cardioprotective. So this drug has got cardioprotective effects. So what we mean by that is it decreases the risk of MI. Okay, MI meaning myocardial infarction. Okay, so your mortality will reduce. It has got indirect cardioprotective effects as well by reducing low density lipoproteins. Okay, and it also decreases platelet aggregation. Okay, so all in all, if we consider all this three together, it has got beneficial we could say that it has got beneficial effect on the cardiovascular system. And in some cases, it produces anorexia, which is kind of mild. So what is anorexia? Anorexia is when people are very concerned about their weight and they decrease their food intake and so on. So anorexia basically leads to decreased body weight. Okay, so that is a beneficial effect again. Okay, so if we consider the other orally used drugs like sulfonylureas, so sulfonylureas, if you consume sulfonylureas, then you gain body weight. Okay, so in this drug, metformin, it reduces body weight. So therefore, it is a drug of choice in obese patients. Okay, by obese we mean overweight. Okay. Okay, so for them it's a drug of choice because of this reason. Okay. So we said the prototype drug in this class is metformin. Okay, and there have also been fenformin and buformin, and we said it has been withdrawn from the US market. So why have they been withdrawn? Okay, so what was the reason why it was withdrawn? Because it caused lactic acidosis. Okay, so what is lactic acidosis? So we said, what does it do? Metformin-like drugs, they decrease hepatic gluconeogenesis. So what is gluconeogenesis? All right, so when we make, you're right, when the body makes glucose from sources other than carbohydrates, it's called gluconeogenesis. So what are the substances from which glucose is made, which is non-carbohydrate? So usually it is from alanine, and it is from pyruvate, and it is from lactate. Okay, so these are the non-carbohydrate sources which get converted to glucose in gluconeogenesis. But this drug, it inhibits hepatic gluconeogenesis, meaning it does not allow either alanine, pyruvate or lactate to be converted to glucose. So in this case, what happens is, this lactate is not converted to glucose because hepatic gluconeogenesis is inhibited. So as a result, lactate accumulates. Okay. Okay, with administration of biguanides. Okay, and that is responsible for lactic acidosis. Okay, so we have written that biguanides cause lactic acidosis, and because of that, these two drugs were withdrawn from the US market. So the question is in metformin biguanide too? Doesn't it cause lactic acidosis? It does, but the instances are comparatively less compared to fenformin and buformin. Okay, so it's relatively safe if the renal function is really good. Okay, but if the renal function gets compromised, then yes, this has got a risk of lactic acidosis. Okay, so we should keep that in mind. Okay. So one of the main adverse effects, the possible adverse effects of metformin is lactic acidosis. Is it very common? No. Okay. But does it exist? Yes. All right. Okay. So now we know why fenformin and buformin was withdrawn from the US market. Okay, because of lactic acidosis. Okay. And what's the advantage of this drug? It does not cause weight gain. And so how is it better than sulfonylureas? It is this aspect. Okay. It does not promote weight gain. Okay. So, yeah. And the other thing to remember about this drug is that it, if you think about it, what does it do? It reduces hepatic gluconeogenesis. It increases glucose sensitivity. It increases glucose uptake. But it has got no effect on insulin secretion per se. Okay? It has got absolutely no effect on insulin secretion. Okay? So we could say that, let's write it down here, that metformin is anti-hyperglycemic. Okay, anti-hyperglycemic, but it is not hypoglycemic. Okay, which means it lowers blood glucose. It lowers blood glucose. Okay, but does not decrease it below. But does not decrease it below the normal value. Okay, so it cannot cause hypoglycemia. But if you think about the other drug, sulfonylureas are secretagogues, meaning they increase the secretion of insulin. Okay, as a result, if they release more of insulin, what's going to happen? Definitely hypoglycemia will be the main adverse effect of sulfonylureas. Okay, so in studying metformin, we are also learning the disadvantages of sulfonylureas. The sulfonylureas, one of the main disadvantages, it promotes weight gain, and secondly, it causes hypoglycemia. Whereas this drug does not cause hypoglycemia. Okay, therefore, it is a drug of choice. Drug of choice, DOC is the abbreviation for drug of choice in the elderly. Okay. In elderly people who don't consume proper meals, okay, who don't consume meals in time, in those patients, this would be a drug of choice. Because if you don't consume proper meals, what's going to happen? Your blood sugar is anyway reduced, and you're also now consuming, say, sulfonylureas. Then what's going to happen? You're going to go into hypoglycemic shock. Okay? Therefore, metformin is a drug of choice in the elderly and people who don't have proper meal hygiene, who don't consume proper meals, and who exercise excessively. Okay, people who exercise excessively. So these people, they are more likely to suffer the adverse effects of sulfonylureas. So in such people, this is a drug of choice. Okay, so exercise, I just put it in there to give you an idea. Okay, that if you do lots of exercise, what's going to happen? Your blood sugar is coming down, and at the same time, if you are on sulfonylureas, then that might cause hypoglycemic shock. So in such patients, the drug of choice would be metformin. Okay. Okay. The metformin has got, in addition to all these effects, it has got an off-label effect. Okay, so let's write it down here. It has got an off-label use. Okay, meaning it's not an indication, but nonetheless it is being used for this condition. And the condition that we are referring to is PCOS. Polycystic so so in such patients also this drug is given. Okay, so it not only has got an hypoglycemic effect, it's also used for the treatment of PCOS. Okay, so let's talk about the ADRs then. There is one more thing that we need to discuss, and that is this drug, let's write note, metformin should be withdrawn before general anesthesia and it should be withdrawn before iodine containing contrast media is administered. Okay. So the problem is why? Okay, so the question is why? The reason being that when a patient is under general anesthesia or is undergoing diagnostic procedures using iodine containing contrast media, then there can be fluctuation in renal function. Okay, so if there is fluctuation in renal function, then there is a slight risk of lactic acidosis. Okay, there is not a slight risk, there is a risk of lactic acidosis. Okay, but so it can be temporarily. So what is the solution? The solution is temporarily withdraw metformin. Temporarily withdraw metformin and administer it in about 48 hours. Okay, so 48 hours after the procedure, okay, or within 48 hours of this procedure, it can be reinstated. Okay, so that's the solution. Okay, so now we know why we should be careful in general anesthesia and then we do diagnostic studies, radiodiagnostic studies. Okay, which brings us to the adverse drug reactions. Okay, so the main one is risk of lactic acidosis. Okay, so this is by the way, if a person has got lactic acidosis, it is managed with, because it is, increase in acids or decrease in pH is what causes lactic acidosis. So how can it be managed? Lactic acidosis is managed with, you're right, sodium bicarbonate. Okay. So as acidosis is managed with a base, in this case it is sodium bicarbonate. Okay, so there is a risk of lactic acidosis. And this lactic acidosis, the risk increases with decreased risk increases with decreased renal function. Okay, so therefore, this drug is not recommended in males with creatinine value greater than or equal to 1.5, and in females with creatinine value of greater than or equal to 1.4, meaning people with compromised renal function, this drug should be monitored. Okay. And the other adverse reaction is it causes GI symptoms. Okay. So which are the most common GI symptoms? Nausea, vomiting, diarrhea. Okay. And general patients might complain of bloating. Okay. And there can be flatulence. What is flatulence commonly called? Yes, it is intestinal gas. Okay. And then there is another effect higher up in the GIT, and that is the patients might feel metallic taste. Okay, and this is kind of unpleasant. Okay, so the strategy, what is the strategy? So this is the problem. Okay, so what is the strategy? What is the solution for this problem? The solution is to start with a low dose. Okay, and then slowly increase, okay, till to a maximum dose. So the maximum dose till the maximum dose of 2000 milligram. Okay, so the commonly used strategy is the standard dose regimen would be, okay, to accomplish this starting with a low dose. So what is usually done is 500 milligram OD once a day is given for 7 days. After 7 days, it is increased to 500 milligram BD, okay, twice a day. That also continues for 7 days. So after that, 500 milligram is administered TID thrice a day into 7 days. Okay, so after that, 2 into 500 milligram is given BD. Okay, so that 2 into 500 grams, meaning 1000 milligrams twice daily. Okay, and that reaches us to the maximum dose. Okay, all right. So the strategy is that people complain of all these problems with if we start with a high dose. Okay, so the strategy is let the body get adjusted. So start with a low dose and see whether the patient tolerates. So after 7 days, the patient comes back and then the patient is reassessed And then if the patient does not show many, doesn't complain of a big problem here, then the next regimen is started. Again, the patient is seen after that, and then that ways it can reach 2000 milligram. Okay. So once you start, okay, so let's write it down here again as a small note. Once started, the regimen should be continued till there is a contraindication. A contraindication, okay. And this contraindication may be if there is therapeutic failure or the patient simply cannot tolerate, okay. But if that's not the case, then it should continue indefinitely, okay. But the patient should be monitored. So what happens in long-term administration? On long-term administration, there can be slight deficiency of vitamin B. Okay, so vitamin B should be, especially vitamin B12. Okay, there can be deficiency of vitamin B12, which can lead to anemia and so on. Okay, so the patient should be monitored, and the patient should be supplemented with vitamin B12. Okay, but then this is for long term. This problem is seen only in very long term administration. Yeah. Okay. Yeah. So the tablets that's available is for 500 milligrams. Okay. So the tablet. Okay, strength of the tablet currently available is 500 milligram and 850 milligram. Okay, so yeah, so we know it's given orally, per oral, right? Okay. Now, in people who have got, even after using this regimen, and we need to stop it in between, then what is the option? Okay, so then the strategy is there are extended release formulation. Okay, so extended release. Okay, extended release formulations exist. Okay, so what's the advantage of this this extended release formulations? They are dosed OD. Okay, they are given only once daily, and they have less severe GI side effects. Okay, and because the release is slow, this extended release, the release is slow. It's slow. Okay, so if the release is slow, what happens? There is no great peaks. Okay, there is no increased peaks, meaning peak concentration will become less. Okay, so this is another thing that can be done if on administering this low dose for 7 days, the patient has got a problem. Then this could be one of the options. Okay. Okay. So what is the indication of metformin? Okay. So under what conditions is metformin administered or prescribed? So if the first strategy for diabetes is to go for non-pharmacological interventions. Okay, so non-pharmacological interventions may be to decrease the weight, to have a plant diet. Okay, so those things, and exercise, those things are non-pharmacological interventions. Now, when non-pharmacological interventions fail to decrease blood sugar, okay, then metformin is the first line treatment. Okay, so this is a first line treatment. Okay, so this is the first line treatment. Okay, and so what does this do is what we're going to look at next. How is it beneficial? Okay, so if we give it as a first line treatment, what changes does it bring to the blood sugar is what we're going to look at next. It lowers blood glucose, lowers blood glucose by about 25%. It reduces blood glucose by 25%, and the postprandial meaning after food, the postprandial glucose by about 44%, and HbA1c. Okay, it lowers it by 1.5%. Okay, so this is the response that we can expect. Okay, so based on this, we can titrate the dose, as well as we can monitor the patient for adequate control of blood sugar. Okay, so this gives us the idea about the kind of targets that we can achieve with respect to blood sugar after administering metformin. Okay. Okay. So let's summarize all this information and write the advantages of this drug. Okay, so the advantages of biguanides. Okay, so what was the first advantage that we talked about? Yes, it does not cause hypoglycemia. Does not cause hypoglycemia. What's the second advantage? Right, it does not increase body weight. Okay, therefore it's a drug of choice in overweight or obese patients. And what's the other advantage? The third advantage is, which we did not discuss, the third advantage is that it can be given, can be administered as monotherapy or in combination with monotherapy or in combination. Okay, combination with any class of glucose lowering drugs. It can be insulin-like drugs, insulin, or oral anti-diabetic drugs. Okay, they can be combined with any hypoglycemic agent. Okay, but the recommendation of the combination, the oral anti-diabetic drug, the recommended combination is if it is, let's try to draw here. The recommended oral anti-diabetic drug with which metformin should be combined is either incretins or sodium glucose transporters. Sodium glucose transporter 2 inhibitors. Okay. So theoretically, metformin can be combined with sulfonylureas, they can be combined with insulin, they can be combined with any other oral anti-diabetic drug. But the preferred combination with respect to oral anti-diabetic drugs is to combine it with incretins or the sodium glucose transporter 2 inhibitors, okay, which reduce the absorption. These drugs reduce the reabsorption of glucose from the renal tubule. Okay, right. So this is the preferred combination. Okay, and let's look at the disadvantage. If that's the advantage, then what's the disadvantage? Okay, so the disadvantage is that this drug is, let's write number 1 here. This drug is ineffective in the absence of insulin. Okay. So what are the conditions where the insulin is absent? Let's say if there is a hepatic impairment or there is heart failure. Okay, so hold on. These are the contraindications of this drug. This drug is contraindicated in hepatic impairment, in heart failure, in chronic kidney disease. Okay, so these are the contraindications. So it is ineffective in the absence of insulin. So if a person has got pancreatitis, then this drug wouldn't be the drug of choice. Okay, ineffective in the absence of insulin, like example, pancreatitis. Okay, or pancreatectomy. If the patient doesn't have pancreas, obviously it doesn't produce, he or she doesn't produce insulin. Okay, so pancreatectomy. Okay, so the removal of pancreas, the procedure, this is pancreatectomy. Okay, so in these patients, it is ineffective. Okay, so if there is any condition where there is absence of insulin, then this drug is not effective. Okay, so yeah, and chronic kidney disease, and if the renal GFR, okay, glomerular filtration rate is less than 30 ml, then this drug should not be given. Okay, so these are the contraindications, and this is one of the major disadvantages. Okay, it doesn't have very many disadvantages. Okay, so it's got very few disadvantages. Okay, it has got more of advantages. Okay. Yeah. So if we are asked what is the advantage of metformin above or metformin above sulfonylureas, then we list out these advantages. Okay? And those are the advantages of metformin over sulfonylureas, which means by now we should be able to say what are the disadvantages of sulfonylureas as a class of drugs, right? Okay, so yeah, so that is the most important aspects about metformin. Let us conclude our discussion on metformin by looking at the structure of metformin. Okay, so we said that it is a biguanide. Okay, so which means it has got a guanidine moiety. Okay, and what's the structure of guanidine? Okay, so this is the guanidine moiety. Okay, and what is metformin then? It is dimethyl guanidine. Okay, so the structure is dimethyl. So there should be two guanidine molecules. Okay, so the structure would be dimethyl guanidine. So two molecules. It's NH, and that would be combined with another moiety. Okay, so that is metformin. Okay, so chemically it is a dimethyl guanidine. Okay, so with that, let's stop our discussion here on biguanides. Oh, and let's add a note on the pharmacokinetics of metformin. Okay, so what's the pharmacokinetics? Absorption. So it is absorbed per oral. It has got bioavailability of 50%. Okay, and because it has got a metallic taste, okay, so we said one of the adverse effect is that it's got a metallic taste, so it should be administered with food. Okay, because why should it be administered with food? Because it decreases the metallic taste. Okay, but what's the problem of administering with food? Food may reduce absorption. Okay, so we should be aware. Okay, so titrating the dose, that should be taken into consideration, but patient acceptability will increase if it is administered with food. Okay, so that's about absorption, distribution. Okay. It is the protein binding. Protein binding is minimal. Okay, so doesn't cause very much drug interactions. Okay, because if it is highly protein bound, then the drugs which can displace it from the binding site can cause drug interactions. So that interactions will be seen more with sulfonylureas. Okay, so sulfonylureas are extremely protein bound. Okay, so they have got lots of drug interactions and metabolism. Okay, so this is not metabolized in the liver. Okay, so there is minimal metabolism of this drug. Again, this is an advantage over sulfonylureas. So sulfonylureas are extensively metabolized in the liver, sometimes into active components and sometimes into inactive. But metabolism definitely happens. Now, if the person has got a problem with their liver, like hepatitis, then sulfonylurea might not be the best drug, but this drug can be given instead. Okay, so that doesn't occur because this is the first line drug. Okay, but we should be aware, right? And excretion. It is excreted through the urine. Okay? So that is the reason we should be concerned about renal failure. So if there is a decrease in glomerular filtration rate less than 30 ml, then what can happen is this drug can accumulate in the body, and there is increased chance of lactic acidosis. Okay. But the important point in pharmacokinetics is that it is excreted through the urine. Okay, so this we have discussed ADME of the drug. Okay, so in the preceding discussion, we have covered the dynamic properties of this drug. Okay, and so yeah, so on this note, let's stop our discussion on biguanides.